useful for people who don't know what they're doing.
What have they done?
It just looks different. It probably doesn't look different, Ahmed. I'm just a bit confused, you know.
Okay.
Right, Anish, let's start.
Yeah.
Okay, so today me and Ahmed are going to be covering postpartum complications, which we've divided into hemorrhage stuff. So primary hemorrhage, secondary hemorrhage, and placenta accreta, which I'm going to be doing, and then the mental health stuff. So baby blues, postnatal depression, and postpartum psychosis, which Ahmed is going to be doing. If you've got any questions, like usual, just put your hand up or write in the chat as we go along. And yeah, there's some cases and some SBAs. So try and get involved in the chat. And the lecture might be slightly longer than an hour because it is quite a lot to cover, but hopefully we'll go through it. Not too quickly, but not too slowly either. Oh, okay, so the first part, we're starting with a case. So this lady has just delivered twins vaginally at 38 weeks. She is G4P5 after delivering her twins. She insisted on having an unmedicated natural delivery and was consequently in labour for 14 hours before giving birth. She's lost around 1.4 litres of blood and is complaining of dizziness. So what do we think is the most likely underlying cause of her postpartum hemorrhage? What are the risk factors for postpartum hemorrhage? And what methods can be reduce the chance of postpartum hemorrhage? So if anyone's got any options, just write in the chat. And can anyone explain to me also what the G4P5 is? If anyone's got any ideas, pop them in the chat. Anyone? Don't worry if you don't know, just anything that you think might go with the risk factor. Yeah, so 4 pregnancies is G4, she's had 4 pregnancies and 5 live births, correct. That always catches people out, or sometimes people are like G1, P2. It means they've had twins. Okay, so can anyone think of anything? What do you think might be causing her postpartum hemorrhage?
I guess in the exam, like, this is effectively analogous to saying what is the most likely cause of postpartum hemorrhage, just generally.
Yeah. You try it, Tony. Good idea, Dominic. Yeah, well done. So anyone think of, looking at the case, any risk factors that we've got for her to have postpartum hemorrhage? We are going to go through all of these as we go through the presentation. I just thought it was quite a nice way to start, is going through stuff. Yeah, so having a multiple pregnancy is a risk factor. Preterm, not so much a risk factor, it's more risk factor for like other things. But so twin pregnancy. Some of the other ones that you could look at in this case would be the sort of prolonged labour, it's quite a long time. The fact that she's had, this is her 4th pregnancy. So having many pregnancies is a risk factor, because obviously the uterus is like being stretched a lot and been through lots of births. So they're the ones that we think about so far. And then can anyone think of anything that would reduce the chance? Particularly look at the fact that she had an unmedicated natural labour, so she's not been given any medication. That's not that, well, it's sort of niche. Yes, oxytocin. So we'll come back to that in a minute. Lizzie, so, right, firstly, primary postpartum hemorrhage is blood loss more than 500 millilitres within 24 hours of delivery. So minor is usually between 500 and 1,000 millilitres, and major is usually over 1,000 millilitres. It occurs in 5% of deliveries, so it's actually quite common. And the mother may show signs of hypovolemic shock if she's lost a lot of blood. So things to look out for are like dizziness, palpitation, shortness of breath, tachypnea, prolonged capillary refill, tachycardia, low blood pressure, and pallor, just the general things. But you might get a question in the SBA which kind of explains that a woman is shocked, and you know that after giving birth is a high risk that she's got postpartum hemorrhage. Okay, there are 4 T's, which are the etiology. Can anyone name them? Anyone know what the 4 T's are? Got some. So trauma is one, tone is one. It's not thrombus as such. It's like yeah, I guess thought it was thrombus, thrombin, and then tissue. So we're going to go through them all. So the first one is tone, which is uterine atony, and this is the most common cause of primary postpartum hemorrhage, and it basically is when the uterus fails to contract. And there are three main causes which are normally contribute together. So basically, the uterus fails to contract adequately following delivery, and it's due to lack of tone in the muscle. And usually what happens is when the uterus contracts, it compresses the intramyometrial blood vessels and they stop bleeding. When you have uterine atony, it doesn't contract, so the blood vessels aren't like squished down, so they just keep bleeding. So the main causes are uterine overdistension, so multiple pregnancy, having polyamhydrosis and having a big baby. Then uterine exhaustion, so a prolonged labour, or a rapid labour, because in a rapid labour, usually it's really, really quick and the uterus doesn't really get any chance to relax. Whereas in a like ordinary or normal like length labour, you start off with slower contractions and then they gradually get faster, so it's not too much strain. Having many children and then the use of oxytocin can cause exhaustion because it can increase the contraction. So for example, if a woman's got like slow progression, you might give her oxytocin to increase the contraction frequency. And then uterine distortion, so this is things like having fibroids while being pregnant, then having placenta previa, placenta accreta, or placenta abruption. The next one is tissue. So this is retained products, placental products within the uterus, basically, which prevent the uterus from contracting. So these are things like retained placental products, and they're like the membranes of the uterus or blood clots or like lobes, that kind of thing from the uterus, which are still there. And then you have placenta accreta, which we're going to come on to, and then abnormal placentation. So when it goes in, the placenta doesn't implant in an ordinary way. Trauma. So this is damage to the reproductive tract during delivery. So things that you think about with this would be like tears and episiotomy are the most common type. So especially episiotomies, because they can often bleed quite. Normally when they do, not tears, often when you do an episiotomy, you normally try and pick whereas there's minimal vasculature. But tears, obviously, they're natural and they can bleed quite a lot, especially if they don't realise they've happened. C-section, obviously, is traumatic. And then using instruments. So the ventouse is not as bad for trauma, but the forceps, because they go around the baby's head, they are often cause quite a lot of they can cause internal trauma to the mother. So there are things to think about. Other things is uterine rupture and uterine inversion, which is basically when the fundus of the uterus prolapses into the uterine cavity, and that basically stops the uterus contracting because it's like a weird mass in it, if that makes sense. Please let me know at any point if what I'm saying doesn't make sense. And the last one is thrombin, which is like pre-existing coagulopathies or like vasculature abnormalities. So vasculature problems can be like hypertension and preeclampsia. And then amniotic fluid embolisms, or if a woman's got severe infections like sepsis, for example, they can cause clotting abnormalities, so she can keep bleeding. Then coagulopathy, so von Willebrand disease, ITP, DIC, and HELP syndrome. So those are all things that cause coagulopathies and therefore prolonged bleeding. And then therapeutic anticoagulation. So a woman might be on anticoagulation because she's got high VTE risk in pregnancy. So she might be older, she's had a clot before, it's her first pregnancy, that kind of thing. And usually you should give the last dose of low molecular weight heparin should be 24 hours before the planned C-section, or hopefully 24 hours before she goes into labour. But obviously in some places you can't predict labour, so you might give the injection and then the woman goes into labour like 3 hours later. She's high risk of postpartum hemorrhage because of that. Okay, so this is the management of postpartum hemorrhage. I tried to put it in a little diagram, which I think hopefully will be more helpful. What I would say is I've got all the doses obviously on here, but don't worry too much about the dosages. You just need to kind of know the steps that you go for. So the first thing is call for help. If anyone's ever seen one of these, they literally like pull a trigger or cord and loads of people run in. And it is a serious emergency because these women can bleed out and you need to stop it urgently. So the first thing you do is you give uterotonic agents, which basically try and increase the contraction of the myometrium. So there's things like syntocin and augmentin. And as it says there, augmentin is contraindicated if a woman has hypertension. So that's important to note for SBAs. If you get an option of either of them, but she's got a history of hypertension, you obviously don't give the augmentin. You can also then give tranexamic acid, which will help with the blood clotting, and also uterine massage through the abdominal wall. So basically you try and like squish the uterus from the belly, like you just press on it from the belly and try and squish it down. Then you can try IV syntocin infusion. If that doesn't work, you can then try bimanual compressions, which basically try and stimulate the uterus to contract and compress the blood vessels. But you do one hand goes into the vagina and squishes the uterus that way, and the other hand is on the abdomen, and you kind of like squish it together in like a contraction movement. So that's another method. Then you can use prostaglandins. So you can use IM Bioprost or Misoprolol, but you need to be careful because in asthmatics, you can't give carboprost in asthmatics because it can cause bronchoconstriction. The next thing, so the green options, the dark green options are surgical. So the first surgical option is intrauterine balloon tamponade. So these people are rushed then, if nothing else is working, you rush them into theatre. And basically just put a balloon in to try and squish the arteries and stop them bleeding. If that doesn't work, you can try one of these many other things. So this is like artery embolization or ligation. These are obviously more serious, but if you need to stop the bleeding, you do that. And the last option is a hysterectomy, which is another life-saving procedure. 2 doctors need to sign off on this. It's not something they just do. You need to have 2 consultants need to sign off, because obviously a woman can no longer bear children if you do that. So it's emergency, but you need permission from 2 doctors before you do that. And then what you can do in prevention is what you would do is you give active management of the 3rd stage of labour, and basically you give an IM oxytocin, which is like 10 units in a vaginal delivery, or 5 units in a C-section, and this is given when the baby is coming out. So when the baby comes out, you give it usually in the thigh. And basically it helps prevent the risk of postpartum hemorrhage, and it's been shown to be up to 60% effective. So that is one of the most useful and the best methods, which they try and advocate for. So even if a woman doesn't want an epidural or doesn't want any medication, the labour team will try really hard to make sure they can give this, because it decreases the risk of postpartum hemorrhage. So management of tissue. Oh, sorry, Anush.
Yeah, I was just going to say, if you go back to the diagram for a second, I think this is like a lot to remember, and like this is one of those diagrams that does come up, and like it could totally be like a AT assessment or something like that. And I don't know just how you like remembered it, but like I always used to split it into basic resuscitation measures, like starting fluids, catheterizing, your usual resuscitation stuff, medical stuff that you can do. So those are the drugs, and then the surgical stuff you can do. So like if you can kind of categorize it, as with most things, it's a bit easier to remember. I don't know, Jess, did you have any Aiden memoirs?
Not that I can remember, but I think the most important things to remember are giving the uterotonic agents at the start. So giving the syntocin or the augmentin, and then the intrauterine balloon tamponade is the first surgical method, because for example they might say all medical management's failed, what would you do next? And the first surgical method that you always try is intrauterine balloon tamponade, because it has the least detrimental effect on like a woman's uterus overall, if that makes sense. So I would try and learn those, and then if you can, fill in the gaps, but don't worry too much about the other ones. But you do need to know roughly what you would do. Any questions about that? Okay, we'll go on. So management of tissue is you basically need to remove what is there. So these women are normally taken into theatre, and they will just try and get rid of it. Trauma, you need to repair it. So in tears, so grade 1 and 2 tears can just be repaired in the labour room. Grade 3 and 4 tears need to be repaired in theatre, because they're much more serious, and they need a follow-up with a obstetrician, whereas grade 1 and 2 tears can just be GP follow-up. That's an important difference to note, is that grade 3 and 4 tears need repair in theatre, and they need follow-up by a obstetrician. And then if it's a thrombin problem, you need to try and correct the clotting abnormality. So you just kind of throw blood products at them and fluids and that kind of thing. Any questions? Also, I haven't written it in this presentation because it's getting a bit long, but you do need to know the different types of tears. So we'll maybe go over that later. There's 4 different types, and you need to know what they are. Okay, so complications. Can anyone think of any complications of postpartum hemorrhage? Hypovolemic shock, yep. Anyone? Oh, sorry, that wasn't meant to happen. Anyone else? Death, yes, that is a sad, but can happen. Thought ischemia, yeah, you can get things like that. So you can have death. So it causes 10% of maternal death, postpartum hemorrhage, which is a very significant cause. Hysterectomy, that is a complication. Women can use their uterus, and obviously this is your first pregnancy and you're very young and you wanted more children. That's a very serious thing to happen. DIC, organ failure, and acute respiratory distress syndrome. These are kind of things that occur in major shock. And then Sheehan syndrome, I don't know if any of you have heard of that. Basically, it's pituitary hypoperfusion causing pituitary necrosis and then hypopituitarism. So you get amenorrhea and then hypothyroid and hypoadrenalism. So in an SPA, it might present as a woman who's given birth like 3 months ago and now her period hasn't come back and she's got symptoms of hypothyroid, and that's like what could possibly have gone on, and she had a postpartum hemorrhage and she has Sheehan syndrome. So that is that's one to remember for SPAs, but I don't actually know how common it is. Anush, Ahmed, do you guys know how common it is? I don't think it's very common.
It's used as one of those sort of discriminator questions because it's not common at all. It's fairly niche because we can control PPH fairly well nowadays. It happens with really severe bleeds, but they like throwing it in as a sort of, ooh, let's see who gets this question.
I did see a case of it on Obs and Gynae, but I am not a barometer for how common things present.
He really is not.
Okay, so back to the case. So the things that were risk factors were the fact there were twins, the fact that she has had 4 pregnancies before, the fact she was unmedicated, so she probably refused to have the oxytocin infusion as her IM injection, and the fact that she had a sort of longish labour. So she had uterine atony, which is the most common cause. She had uterine overdistension and exhaustion. And then you can prevent it by giving active management in the 3rd stage of labour, so the IM oxytocin. Have you got any questions about that? We will go on to placenta accreta. Has anyone got any ideas what placenta accreta is? And we will be going over, there are some other placenta things like placenta previa and that kind of thing. We'll be going over that in an antepartum lecture, which I think I'm doing next time I do a lecture, so maybe 3 weeks' time. So something to do, someone has said, is it something to do with misposition of the placenta? So and someone else said, Lizzie said, is it when the placenta grows too deep? It is. So what happens is the placenta grows too deeply into the uterine wall. So basically after the child is born, part or all of the placenta like remains attached to the uterus. So usually once the baby's born, you can the placenta comes out afterwards. Normally about half an hour afterwards is normal. After an hour, you start worrying. If the placenta does not come out by an hour, you're a bit concerned. Well, you're very concerned. But after about half an hour, usually the placenta just it delivers effectively and it comes away from the uterine wall and comes out. In placenta accreta, you can't get it off. And it's thought to be due to abnormalities in the lining of the uterus. So has anyone got any risk factors that might cause abnormalities in the lining of the uterus? Endometriosis, surgery, previous surgeries like C-sections, yes. So things are uterine scarring. So this is from previous surgery, like uterine surgery, previous C-sections, or Asherman syndrome, which is usually caused by previous surgery, or D and C, like I can't remember what dilation and called, where you try and previous surgery. yeah, where you retain products of conception, that kind of thing, or when someone's had a termination or a miscarriage when you do that. Then placenta previa is associated with placenta accreta, so we'll come on to that if you don't next time I do a lecture if you don't know what that means. And then having had multiple pregnancies, because the uterus might be stretched, and kind of as it gets stretched and then recontracts, you might have some abnormalities in the lining from having many babies. Right, so there are 3 types of placenta accreta, as you can see on this diagram. Asherman syndrome. Okay, so Asherman syndrome, I don't know if we've covered this already, is a type of condition basically where you have scarring within the uterus. Scarring within the uterus, and basically it's like inside the uterus, and you have adhesions attaching like parts of the uterus together, and it's caused by surgery within the uterus. So usually things like you know, when you terminate a pregnancy, or like manual evacuation or termination of pregnancy, or retain products of conception, when you do that after someone's had a miscarriage, you basically like can scar the uterus, and then these adhesions can form within the uterus, and it might present as a woman has every time she has her period, she has reduced bleeding but really bad pain, and that's something that how it like can present. Does that make sense, Lizzie? Yes, okay. Right, so there are 3 types of placenta accreta. Placenta accreta is the most common type, and it's the mildest type, which is generally like how the most common you'll see, but they're not very common overall. So basically the placenta adheres to the myometrium rather than being restricted within that. I've got no idea how you say that, but basically if you look at the little diagram, it starts to go into, if you look, you can see a normal one. Can you see my mouse? Can't, can you?
No, you can't see my
Okay.
sorry.
So basically the placenta goes into the wall a little bit. Then you have placenta increta, which is basically where it invades fully into the myometrium. And then you have placenta percreta, which is basically when it invades through the myometrium. So it's gone through the myometrium and out the other side. So it goes out the uterine serosa, and it can attach to other organs. So like because it's gone literally through the uterus lining, it can attach to the bladder and stuff. And that's the most serious type, as you'd expect. It's also the rarest type, but it can cause serious complications because the uterus is now kind of like bound by the placenta to other organs like the bowel or the bladder, and it's really hard to get the uterus off and out. And you can't just like pull it out like you normally would because you might damage other structures. Does that make sense? The main type you need to know about is placenta accreta, because that is the most common, but no, overall they're not particularly common. So the symptoms are, often it's asymptomatic and a woman doesn't know she has it, but you can sometimes get painless bleeding in the 3rd trimester, but most of the time it's asymptomatic. And basically what happens is you'll get excessive bleeding after the baby's born because the placenta is not coming out, so the uterus can't contract and just keeps bleeding, and the placenta is trying to disattach, but it can't disattach because it's implanted too far, and you just get loads of bleeding. So basically what happens is after the baby's born, the placenta doesn't come out. So you get to that hour mark and the placenta is still not delivered, or maybe some of the placenta is delivered, but you can tell it's not all of it, and you can't work out why the rest of it is not coming out. So investigations, sometimes it's detected at the 20-week anomaly scan. So you might realise in the scan that the placenta is growing abnormally. It looks like it's growing too far. Or someone might have placenta previa and you think, oh, maybe they also have accreta, but you're not sure. If you think they do, you do an MRI. Basically, and that makes it easier to establish like the degree of invasion. So if looks like there's an abnormality in the placenta at 20 weeks, or any point, so say a woman's having like regular scans for growth or something, you would do an MRI because that's the best way to tell. But otherwise, it's identified at birth when the placenta just doesn't come out. So the management is ideally if you spot it beforehand and then these women have an elective C-section, that means that you avoid the whole thing of the placenta not coming out, and you can do the C-section, take the baby out, and then you can easily remove the placenta because you've opened up the uterus and you can take the placenta out that way. So you can do that by, next step is surgical removal of the placenta. So basically you like scrape it out or burn it out basically. And if it's not possible to do this, you might resect part of the myometrium, or if you can't do that, you have to resect the whole you have to do a hysterectomy and you have to take out the whole uterus, which is obviously more extreme. So they try not to do that. They'll try and just remove the placenta through like scraping it out, basically. And then these people will bleed a lot because the placenta is growing too far into the uterus, so the uterus just keeps bleeding. So you need to stop the bleeding. So hopefully once you have scraped out the placenta, they will stop bleeding, but sometimes they don't, and you need to do, as I said before, like an intrauterine balloon tamponade, uterine artery ligation, or you'll need to do a hysterectomy. So ideally you want to avoid hysterectomy in these cases, but sometimes it has to happen if they're bleeding excessively, and if the placenta is invaded really far, often it's really difficult to counteract that and to try and stop the bleeding. So quite often this is what you have to do. And one other thing to note is that when you do the when you cauterate the placenta, so basically scrape it out, that results in a lot of bleeding. So often you can give methotrexate afterwards, and that stops or helps reduce the bleeding. I have no idea how, but it can help reduce the bleeding. So that's often tried first before they do anything else, because ideally you don't want to have to go to the other methods of resecting part of the uterus. Does that make sense? We're nearly done on this half. So secondary postpartum hemorrhage. Can anyone tell me what that is? Any ideas? Yes, so basically secondary postpartum hemorrhage is bleeding after 24 hours until 12 weeks postpartum. So the causes are usually retained fragments of like placenta or just tissue within the uterus, so it's not contracted fully, and sometimes because you can get an infection, which is endometriitis, and the infection is basically caused because there's retained products there, you get the infection. So usually you don't get the infection without the retained products, like you get retained products or retained products and infection. And then you can also get some abnormal other things. So you can get abnormal involution of the placental site. This is really rare, and basically what happens is there's an adequate closure of the spiral arteries which attach to the placental site. So because they're still present, they still bleed a bit, but it's not very common. The most common thing to be aware of is retained products. So symptoms, basically you just get prolonged vaginal bleeding. Often it is much lighter and less severe than postpartum hemorrhage. So it's people like usually say you might get spotting and then like a lot of blood at once, and then more spotting and a lot of blood at once. But the lot of blood is still much less than postpartum primary partum hemorrhage. And the uterus will still be enlarged because it can't involute, so it can't get smaller and contract because of the stuff that's in there. And if you have an infection, you just have general symptoms like fever, pain, tenderness, foul-smelling discharge, or loci. Does anyone know what loci is? Because I didn't know that for ages and it really confused me. Okay, well basically loci is like blood and discharge that you usually get after birth, and you get it in C-sections as well as vaginal births, till about 6 weeks, usually postpartum. It's usually quite heavy for the first week or two, depending on the woman, and then by 6 weeks it's very, very light and usually stopped. But it's usually a bit bloody and dischargey. But if it's like foul smelling, then you're worried that there's an infection there as well. Okay, so investigations you would do for this. So you do an ultrasound to look for the retained products, and then you can do bloods to look for the infection, and then you might do vaginal swabs for cultures and stuff if you're worried about infection. And then management basically is evacuation of retained products of conception. So you basically go in and suction out the products to remove them. And then you give antibiotics if you've got endometriitis. Don't worry about the ones you give. I'm not sure why I wrote it on there, but don't worry about those. But you give antibiotics. Okay, so an SVA. Sally is a 31-year-old who's just given birth to her second child by spontaneous vaginal delivery at 39 weeks. Her pregnancy and labour have been uncomplicated, but she has had an hour. It's been an hour and her placenta has still not delivered. She has now lost 0.9 litres of blood, despite receiving IM oxytocin as the baby was born. Her first child was born via emergency C-section due to abnormalities on the CTG. What is the most likely cause of her postpartum hemorrhage? Okay, usually I do this on Menti, but I don't have Menti. So you just want to write the answers in the chat? I don't know. Let's just do that. Any other options, anyone? Okay, so we have spontaneous vaginal delivery, uncomplicated pregnancy and labour. Placenta has not delivered and it's been an hour. She's obviously got postpartum hemorrhage because she lost more than 500 millilitres, and she has had a previous C-section. So uterine atony, she doesn't actually really have any risk factors for that. The labour was spontaneous and uncomplicated. If it was like prolonged, you think about that. The placenta is not delivered, which in uterine atony is not usually like a sign of that. Vaginal tear, although possible, it wouldn't cause retained placenta, and also there's no mention of a tear if she had an uncomplicated labour, and you wouldn't necessarily say it was uncomplicated if the woman had torn. Endometritis, that usually occurs after 24 hours. It would be very uncommon to get an infection straight away that she didn't have before she gave birth. And then placental abruption, it doesn't usually occur, well, it doesn't occur postpartum, and it actually makes the placenta easier to remove because there's blood between the placenta and the uterine lining, so the placenta's already come away. So the option here, our answer here is placenta accreta. So I think that is my half finished. Yes. Has anyone got any questions about that? That was quite quick, but there's not much to postpartum hemorrhage. You just need to basically learn about uterine atony because it's the most common. The management of that. Sorry, I'm trying to count my camera on. The management of that, and then a little bit about placenta accreta, because although it's not very common, it's quite a significant cause of postpartum hemorrhage, and it's quite a dangerous one. So, any questions?
I would say it's an important topic both for exams and for like life.
Yeah, it's a really important topic. Even if you're not going to go anywhere near obstetrics, it's an important topic.
Yeah.
I think the year above us, because we didn't have an OSCE, I think they had postpartum hemorrhage as their like Dr. ABCD OSCE station. So it's definitely something that could come up in an OSCE format. So it's important to learn like what you do, and what you would do is call for help is always the first step, and then follow the management plan. But I think it did come up as their OSCE station when they were in fifth year, the year above us. So I think make sure you do know, go over it. Yeah. Okay. Over to you, Eamon. Ahmed, sorry, I don't know why I keep calling you that. My bad.
Right, is Eamon at Basildon?
Okay.
Is what?
Is Eamon at Basildon? That would probably explain it.
Possibly. Right.
Right. Okay. So we're going to switch over to the psychological and psychiatric sort of sequelae of labour and childbirth. So this is a case that we've got. So we've got a 28-year-old lady who's come to see you, and you're her GP. It's 4 weeks after she's given birth, and she's explaining that her husband's made her come, which is already sort of it's always good to know whether the patient has come off their own accord or because somebody's suggested that they do, or because they've been brought in when we're talking about mental health and psychiatry. Because she's been having more thoughts about harming her daughter, and over the last week they've been getting more consistent. Because of this, she does not feel like she's bonded well with her baby, and she started to feel like an inadequate mother. She explains she's also not sleeping well and has lost lots of weight, but thinks that this is normal for all new mothers. So the first thing is, what are the 3 differentials that you need to consider? The 3 main differentials. Yep, good. Postpartum depression. Yep. Postpartum psychosis is an important thing that we have to rule out. And the baby blues. Perfect. Out of those 3, which one is an emergency? Which one needs the most urgent intervention? So, yep, good. Psychosis. Perfect. And in this lady, what do we think the most likely diagnosis is out of those 3? Yeah, I agree with Lizzie. I think postpartum depression is most likely. We'll talk a bit more about that. Okay, so before we start talking about the parts of postnatal or perinatal psychiatry which medical school expects you to know about, talk about some real life stuff first, and stuff which is more important for us going forward rather than, circling or shading in things on an SBA answer sheet. Pregnancy is hard. Giving birth is really, really hard, and they are incredibly, incredibly stressful. Obviously, midwives are trained to keep an eye out for, psychological complications after birth. And the reality is, with things like baby blues, considering how many women it affects, you can almost argue that it's not even that pathological to, feel a bit down after you've given birth, because it's so common. So when you're dealing with someone who's just given birth, and also consider not just people who've just given birth, but also some of these things such as postpartum depression or postpartum psychosis can happen after a miscarriage or a stillbirth. Do keep an eye out for these things. And I think the most important thing, especially once we talk about some of the risk factors for these things, is it's really, really important to reassure the woman that it's not her fault. Because imagine, like in this case, where you feel like you're an inadequate mother because you feel like you haven't bonded with your baby. It's not your fault. There's lots of stuff going on, likely contributing to it, and it's not because the person's a bad mother. It's because they've gone through a pretty rough time. So we'll start with the baby blues. The other thing is perinatal psychiatry and sort of postpartum psychiatric conditions aren't just limited to those three. You've got postpartum OCD, postpartum PTSD, postpartum anxiety, but the ones that medical school wants you to focus on are those three because they're by far the most common. Right, so baby blues. So how, what percentage of new mothers get baby blues, or women who've just given birth? Oh, whoops. Let's try and see what was on the next slide. And it is quite a high percentage. Yeah, so it's over 50%. In fact, some statistics put it as 85%, which means out of 100 mothers, 15 won't get baby blues, which is the way that I like to look at it. I think it's quite important to normalize the fact that after you give birth with hormonal changes and everything, you are quite likely to feel down or blue for a bit after that. So it typically occurs about 3 days. And the important thing is it self-resolves. And that usually should be in 2 weeks. One of the reasons why I agree with Lizzie about why the previous one is most likely postpartum depression is because it's gone on for more than 2 weeks. Baby blues shouldn't go on for that long. So the important things to let the mum know in terms of baby blues is that usually it's worse around day 4 or 5 after giving birth. That's when it gets worse. What sort of symptoms would you expect in terms of a woman with baby blues? What sort of things might you be on the lookout for? Yeah, feeling irritable, feeling tearful. Yeah, very good. Feeling anxious. Yeah. And these are all really, really important because, yeah, labile, difficulty, emotion. And I think the trend you can see of this is these are all fairly common things after you've had a big lifestyle change or a big change in your life. And, having a baby is a very big change, especially if it's your first one. So in terms of symptoms, emotional lability, like Miguel said, tearfulness, you've basically got all of them. Feeling irritable. Don't forget in terms of the biological things, so difficulty sleeping. Some women may report that they feel confused. It's not very common, but objectively, for example, if you decided to do an MMSE or a MOCA, they're not going to be objectively cognitively impaired. But that's something that some women report. Let's talk a bit about risk factors. So, as with symptoms, where in mental health we like to divide them sort of into biological, psychological, and social, let's just do the same with risk factors. So what biological risk factors can people think of in terms of baby blues? Hormone changes, yeah, which is likely a big part of it. And then I imagine because so many women get it, you know, your hormones always change after birth. Parkinson's, that's interesting. So why Parkinson's? And whilst we're doing that, what about psychological factors? Okay, fair enough. I think an important thing to point out is by the time people usually have Parkinson's, unless it's an acquired or inherited Parkinson's, they are usually beyond the age of having a child. But no, fair enough. I like it. It's lateral thinking. Good. Yes. So past psych history, and this is going to be a recurring theme. Past psych history increases any past psych history increases your risk for a postnatal episode. Perfect. So feeling anxious, you know, afraid of giving birth, which is again quite common, especially if it's your first baby. Having anxiety or depression during the pregnancy, very good. Yep. And what about social factors? What sort of social factors can we think of? Something also to point out whilst people are typing is that with previous history, it goes both ways. So, for example, if you have a history of depression, you're more likely to get baby blues. But if you have a history of baby blues, you're more likely to get depression. And it appears to be that it's worse in the other direction, where if you've had baby blues, you're more likely to get postnatal depression than the other way around. Perfect, huge one. Lack of support. So, to list it off, biological, we've said previous history. Hormonal change is almost as more of an etiology than a risk factor, really. Psychosocial, if the delivery was hard, the change in routine because of a baby, so, you know, disruption to your sleep, disruption to your usual habits, not much support, a difficult relationship, being a single mother, financial stress, babies or having a child is expensive, feeling overwhelmed. Sometimes people might have unrealistic expectations of themselves and think that they're not being a good enough mother. That's something to be dealt with by education. If your baby was born sick or premature, that's a risk factor as well. Okay, so we've said these and you've pretty much gotten all of them, which is excellent. Nice one, guys. An important thing is that you can get it without any risk factors at all. So let's talk about management. So how might you manage baby blues?
Can I quickly interject and say it is important to note that obviously, like, it's very common. If up to 85% of people get it, lots of people won't actually have any risk factors for it. So that's just something to consider if it's presenting in like an OSCE or a history or anything like that. Is you don't necessarily need any risk factors. Yeah. Sorry.
Okay, so management, yeah, reassurance, which is by far the most important thing. A really, really big thing is nobody often talks about how after giving birth to a child, a lot of what people expect is sort of the happy aspect of it. You know, there's a new baby, everyone around is sort of happy. Nobody often is warned about, hey, a few days in, you might start feeling tearful, you might start feeling quite upset, which is a really important thing to let somebody know this will probably happen. That's actually quite normal. And it will go away on its own. Just be, you know, try as much as you possibly can to maintain some time for yourself, to focus on your sleep, get as much support from the people around you as possible. More straightforward things: don't drink, don't take any drugs, recreational substances, which does happen sometimes. But yeah, it's pretty much based on reassurance and explaining and sort of education. Also safety netting. So by the way, look out for this if this happens, if you start getting worried about X, Y, and Z, and we'll talk about the features of sort of the more serious conditions later on. Okay, so postpartum depression, moving on to that, is a step above. Now, this is arising in the months following childbirth. So in terms of epidemiology, there's no real cutoff, but it's regarded that if a woman experiences depression within a year of giving birth, that's sort of agreed upon as, you can start thinking of that as postnatal depression. It affects, does anybody know what the prevalence is? So let's say out of every 100 women who give birth, how many will get postnatal depression? Yeah, perfect. So about 10 to 15%. So again, it's really not uncommon, which a lot of people might be surprised by. They wouldn't expect sort of people to feel low in terms of baby blues or even full on depressed after what is supposed to be a joyful, happy event. So it's usually within 3 months. The most common time is within the first few weeks to a month, and it can last for quite a while. Depressive episodes in general tend to last for a few months, and the important thing is, in terms of symptoms, the symptoms are the exact same as a regular depressive episode. The time cut off is the exact same. So how long does sort of this period of symptoms being present have to last for in order for it to be regarded as an episode of depression? What's the minimum cutoff? How long do symptoms have to persist so that you can call something an episode of depression? 2 weeks, perfect, yeah. So, in terms of diagnosis, you have this thing called the Edinburgh Postnatal Depression Score. If that's ever going to come up in SBA, it's going to be like, what scoring method is most appropriate? 10 questions, each one you can give a score of 0, 1, 2, or 3. So the top score is 30. 13 or above above 13 is regarded as concerning, and it's the sort of thing such as it's in the last 7 days, how has this been compared to your baselines? Things like in terms of laughing, have you been laughing more or less, have you been more tearful? There's 10 of them. The last one's quite important because it's thoughts about harming yourself. So, you know, for example, somebody might score 3 because they've said nothing on 9 of them, and on the last one they're saying, actually, I'm thinking about harming myself a lot. So then obviously within context, that's more concerning than a woman scoring 14 but with 0 on that question. So another thing to remember is that actually a third of these women, their symptoms started before they gave birth. This is something called a peripartum onset. So the symptoms began during pregnancy, and of course, if a woman has miscarried or had a stillbirth, they're still likely to get it. They've had the same hormonal changes for a start, and also it's incredibly traumatic. So, symptoms, we said, sort of similar. So you've got your same core triad, which is not what's on here, but the core triad of low energy, low mood, and loss of interest in things which were previously exciting and interesting. So your anhedonia. Obviously, you've got your organic symptoms, such as your decreased sleep, your changes in weight, low energy. But then there are some which are related to the baby and motherhood. So difficulty bonding with baby, which will make you feel guilty. Not really feeling like you're happy around the baby, which will make you feel guilty or inadequate. You get these sort of more high risk things, such as obsessional phenomena, which is the distressing thought that you'll harm the baby. Bear in mind that this is obviously a much publicized thing about cases where a mum becomes unwell and kills the baby, but they're really uncommon. Obviously, you have to risk assess and everything, but particularly in postpartum depression, it's quite uncommon. And then infanticidal thoughts. These are more distressing to the mother than anything. So those are your symptoms. Let's talk about risk factors. So risk factors, obviously including everything that we talked about when we were talking about baby blues. What about other biological risk factors? So we've said previous history or family history. Family history is important here. A woman may not have had a baby herself, but her mum may have had depression after each of her children. She may have had a sister. So it's had family history. Any other biological risk factors? You can sort of divide it into things that are to do with the mother, things are to do with the birth, things are to do with the baby. So in terms of things to do with the mother, a history of sort of premenstrual syndrome, so PMS, particularly if it's severe, increases your risk of it. If you've had a previous stillbirth or miscarriage, that'll increase your risk of postnatal or perinatal anxiety massively, but also risk of postnatal depression. Low vitamin D levels in the mum. If the baby is sort of has a bit of a difficult temperament, so always crying, for example, breastfeeding's a really big one. If the mum's struggling to breastfeed, then that's quite a big one. Additionally, if the mum can't breastfeed for whatever reason and has to use formula milk, then often they might report feeling inadequate, not a good enough mum. So that increases their risk of postpartum depression. A traumatic birth, either psychologically or physically, usually it's the same. What about psychological? So those are our biological ones. What sort of psychological things? So previously you said psychological in terms of anxiety around labour and birth. And those are risk factors for baby blues. But let's think of more serious things that might increase risk factors for, increase the chance of depression. Some of these are in hand with risk factors for depression. Others are more linked to pregnancy and birth. Any ideas? Yeah, perfect. So psych history is really, really important. So if they've got previous history, more specific to sort of the antenatal and postnatal period, if the pregnancy was stressful, that increases your risk. If the pregnancy was unwanted or unplanned, that shows an increase in risk. If you've had previous baby blues, that was something that we mentioned. A history of sexual abuse is a big one. Childhood trauma as well, which are more sort of linked with mental illness in general, but also there's sort of vulnerability around the antenatal, sort of the perinatal period, that a previous history of vulnerability associated with, being abused can make it quite traumatic. And then social, we've said some things with baby blues, such as being a single mother, being in a poor relationship, a lack of support, stress about childcare. You've got 4 other kids. What are you going to do with them whilst you're looking after this new baby? There are some which don't immediately pop up to mind. So an interesting one, actually, which might be not too surprising if you sort of think about it a bit, is that if you are an LGBT mum, so for example, if you're a gay woman who's just given birth, your risk of having postnatal depression is quite high. That's thought to be perhaps due to difficulties finding support, or similar mothers for support, less likely to have family support, perhaps, especially within certain cultures. And a really, really, really big one is if you've been the victim of domestic violence. That hugely increases the risk. So always be on guard in terms of that's part of your safeguarding things, looking out for that sort of thing. If there's been a risk of domestic violence, that hugely increases the risk of postpartum depression. So we've got here hormonal changes and obstetric complications with family history, a past medical history, and severe baby blues, and also lack of support and recent adverse life events. In terms of management, psychological is the mainstay. I'll be honest, there's not that good a set of evidence for SSRIs and so on being that useful. In some cases they can help, but psychological is generally your best bet. So things like CBT, interpersonalized behavioral therapy, psychodynamic psychotherapy, and counseling. And usually midwives are trained in some of these techniques, but you have specialized psychologists for postpartum mental illness, and psych might need to review if it's quite severe. Medication, here's an important thing. Sertraline or paroxetine are first lines because very little of them gets into your breast milk. And then ECT if it's very, very severe. ECT is safe in pregnancy. It doesn't affect the baby, which is obviously any mother is worried about, will this affect my baby? And then social is essentially having more support, being in a more supportive atmosphere. Any questions about that, then drop them in the chat. Finally, we're moving on to postpartum psychosis. Postpartum psychosis is actually about an umbrella group of about 20 different conditions. You've got the biggest one is postpartum mania with psychotic features, but psychosis is broad. Remember, as far as I'm concerned, if you're talking to me, psychosis is the most terrifying thing in medicine, and postpartum psychosis is no different. Anything that you can see in regular psychosis is possible in postpartum psychosis, including things like delusional misidentification. So you've got your delusions like your Capgras delusion, so your imposter delusion, Fragoli delusions, where you think loads of people are actually the same person out after you. But more specific ones include things like the changeling delusion, so you believe that somebody swapped your baby around, and delusions of possession, so belief that your baby is possessed by some malevolent entity such as the devil. What's the prevalence, do you think, in terms of, for a woman with no family history and no mental health history, what's the chance of getting postpartum psychosis? Lower than 1%, so it's actually 0.001. So it's 1 in a so it's 1 in 1,000. So 1 in 1,000 women, or 1 in 1,000 births, there'll be postpartum psychosis. It's really scary. It's really scary for the woman, obviously, because entirely everything that is happening is real to her as far as she is concerned. It's really scary for the partner, obviously, if there is one. And it's a psychiatric emergency, as it says in red over here. Why is it a psychiatric emergency? Because there's a huge amount of risk to the mum and to the baby. It usually begins quite quickly, so it can happen within the first few weeks. And if it's treated, you can get recovery. So within 6 to 10 weeks, you can get recovery. Symptoms are very much similar to your psychotic symptoms. So you've got your positive symptoms, which are your hallucinations and your delusions. And the delusions and hallucinations don't necessarily have to be around the baby, but often are. There's often an aspect based on that. And you have your negative symptoms, such as social withdrawal and so on. But it's the positive symptoms, which are the bits that you're scared of. So in terms of hallucinations, command hallucinations, remember, are very, 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 very high risk. What's an important thing when, I don't know if people were there for when I did psychosis, I think at some point during the last term, but whenever you're thinking about diagnosing psychosis, what's the important thing to remember about psychosis as a diagnosis? When can you diagnose psychosis? What do you have to have done before you can diagnose a psychotic episode? Perfect, yeah, like Liang said, you have to rule out organic causes. And as with regular psychosis, postpartum psychosis can have organic mimics. So can anybody think of something organic, something physical, which might cause something which looks like a postpartum psychosis? So a change in mental state with paranoia and so on. Think of your regular mimics of psychosis, the ones that you want to rule out, and think of something that's quite actually, well, Jess talked about it with postpartum hemorrhage. What's a late complication of postpartum hemorrhage, which may occur a few days later, which is also usually the start of onset of postpartum psychosis. So the most, so shock, you will become, if you are shocked enough, you will become confused and delirious, and that can look very much like you have psychosis. Sepsis, so delirium due to an infection. So let's say you have endometritis because of retained products, and then your mental state just changes. But then if somebody took the time to take your temperature, you've got a temperature of 39.2, and actually you've got hyperactive delirium. You can get thiamine deficiency after pregnancy, so it could be Wernicke-Korsakoff, for example. It could be because of Sheehan's, so because your adrenal function's just gone off and now you're having Addisonian symptoms. Or it could even be hyponatremia because of oxytocin. Bonus points for anyone who can tell me why oxytocin causes hyponatremia. Niche but fun, and I love my pharmacology. And while somebody's doing that, somebody tell me risk factors for postpartum psychosis. What are our risk factors for postpartum psychosis? And remember, psychosis is way more biological than the other ones. So things like being isolated, increased stress will increase your risk of having a episode of psychosis, but it's way more biological. Any idea for risk factors? And yes, it is okay to repeat ones which are already said, especially the most important one which has already been said, mainly just to drill it in. Family history, yeah, like Lizzie said. I want you to pay attention to this bit. We said 1 in 1,000 if there is no history in the family or personal history. If there is family history, that shoots up to 3 in 100, so from 0.001% to 3%. If you have a personal history of, let's say, bipolar type 1 or schizoaffective, and it's your first baby, now this goes up to 1 in 5%. If you have family history, if you have family history, yeah, or you've had postpartum psychosis yourself, and you also have a psychotic condition like bipolar or schizoaffective, that becomes 1 in 2. So we've gone from 1 in 1,000 to 1 in 2 because of family history. Family history is huge. Okay, so risk factors, if it's your first baby, family history, previous history of a mental illness, and your regular ones, social factors. Management. Anybody know what a mother-baby unit is? Because that's our gold standard in this country. Yeah, they're specialist inpatient units, and they're specialists because based on them, as you can tell from the name, the mum and baby are taken to the same place, which is huge because you do not want to separate a mum from her newborn child. So they are usually units where there are special, there's a perinatal psychiatrist, specialized nursery workers, mental health nurses, and the baby and mum sleep in the same room if it's safe for them to do so. Activities together, everything. The average stay is about 8 weeks. But if obviously there's no one nearby, then the mum has to go to a general psych unit and the baby has to be looked after by someone, which is much more stressful. CBT and psychoeducation, not really that useful for psychosis. Again, psychosis, big thing is controlling it with medication. Caution with breastfeeding, which we'll wrap up with, but your big thing is antipsychotics. Involving the family is usually quite useful. Sometimes it might make it worse if the delusions revolve around them, which they can sometimes. But yeah, that's our main thing there. And then in terms of prevention, you always need specialist input. We'll talk about medication as we sort of close up. Lithium, remember, is associated with your Epstein anomaly of the heart. Sodium valproate with neural tube defects, but we'll close up with medicines because that's a sort of hot topic, especially when you're talking about pregnancy. And then, as we said with this case, baby blues, postpartum depression, and postpartum psychosis are your main differentials. You need to urgently intervene for postpartum psychosis, and the most likely one here is postpartum depression. What about this SBA? So if you guys give it a quick read, and then we'll give you guys 30 seconds, and I'll show the answer. So another 10 seconds, and then we shall reveal the answer. Okay. So this is describing postpartum psychosis. The correct answer is admitting the mother to a mother and baby unit. Discharge and reassure would be postpartum blues. Admitting to a unit would be if she wasn't postpartum. Discharging with paroxetine if she was postpartum. Family therapy. Yeah, therapy is not going to treat psychosis, but it's just not. Whatever you hear, however much people will try, if you have a very psychotic person in front of you, therapy is not going to treat them. Okay, finishing up psychiatric medications. What is the most important thing with psychiatric medications and pregnancy? What is the most important thing to consider if you're thinking about stopping a medication? Single most important thing. Besides mother's wishes. Mother's wishes are obviously most important, but alongside mother's wishes, you as the clinician, what do you have to consider? Yes, perfect. Risk of relapse. Never forget that. This is a benefit risk decision, as with any decision to do with medication, and in this one, the consequences could be huge. Remember, in this country, your priority up until up until the point where the child is born is the mother or the woman who is who has the fetus and then the baby. That's your priority. So sure, you could argue along the lines of, well, this if she stayed on her lithium, the baby has a 3 in 100 or less, I think, actually, chance of getting some form of developmental abnormality. But if the woman relapses and then becomes severely unwell and kills herself, then what was the point? So to wrap up, lithium usually is swapped for something like olanzapine or quetiapine because lithium is the one where we have the most evidence for its effects. However, if the woman does decide to stop it, she's strongly advised to recommence it within 24 hours of birth. What's a side effect of some antipsychotics that might make it more difficult to conceive? So now we're talking about sort of the prenatal, preconception period. Yes, perfect. You're on a roll, Lizzie. Brilliant. So high prolactin levels would make it harder to conceive, so you might switch to an antipsychotic which has a lower risk of high prolactin levels. Anyone know which antipsychotic's a good idea for that? It's less likely to cause hyperprolactinemia. So in quotation marks, third generation. Yep, aripiprazole, very good. So aripiprazole, you might switch to that because it's got a lower risk of side effects like hyperprolactinemia. Talking about antipsychotics, there's no real evidence that they increase risk of miscarriage or birth defect. In terms of we're talking about psychiatric medication, antipsychotics are probably the safest in pregnancy and usually shouldn't really be tampered with. The problem with them is because of the metabolic side effects, it can increase your risk of gestational diabetes from 2 in 100 to 4 in 100. But there's also a study which shows that it happens anyway if you've got schizophrenia, and even if you're not taking an antipsychotic, your risk of gestational diabetes is higher, possibly because of the effects of the disease on lifestyle. Breastfeeding is a whole different ball game. Like Jess had put earlier, sertraline and paroxetine are your first lines because those are the ones which are least carried over to breast milk. Antipsychotics, again, thought to be fine. There's no evidence to suggest that they do or don't cause it, so it's sort of unspecified, except clozapine. Remember, clozapine is always your exception. The problem is clozapine, you've got your risk of agranulocytosis and it lowers the seizure threshold, so you don't want the baby having that. Antidepressants, finally, SSRIs, yes, in the first trimester have an increased risk of birth defects. It goes from something like 0.2%, which is normal, to up to 1.2%. So it's sort of a 5-fold, 6-fold increase relatively, but in the absolute, it's about 1%. Basically, again, risk assessment. If it's a mild case of depression, you can discuss taking them off of it. If it's severe, you're probably not going to want to play with that because of the risk of suicide. So it all boils down to risk assessment. Antipsychotics, basically fine. SBAs, antidepressants, not so fine. Lithium, definitely not fine. But yeah, any questions about medications and stuff during pregnancy and breastfeeding, then drop that. But otherwise, I'm sorry that I've overrun. And yeah, Anisha just dropped the thing for the feedback form, and I hope that was useful. Thank you guys for chiming in. Joining in, not chiming. Well, you've also chimed in.
Thanks, everyone.
Normally, yeah, if the woman is stable enough, yeah. So the psychiatrist will probably decide to wean them off lithium and start them on an antipsychotic like olanzapine or quetiapine is usually the ones that you go for first. However, let's say you've had a woman who in her previous pregnancy, they tried doing that and she got really unwell, then you might actually consider keeping them on lithium. So there are cases where you even might think, actually, it's not worth trying to stop the lithium because in the past she got really unwell. But generally, yeah, you try to stop it and replace an antipsychotic because they've got mood stabilizer function as well and aren't so bad for fetuses. Yeah, I do. So it's really important if a woman is trying to become pregnant, they're advised to let their GP and their mental health team know. However, obviously pregnancies can come as surprises, in which case the woman is told to let her mental health team, if she's under one, her GP know as soon as possible, so then they could start thinking about that. There's a whole sort of plan thing with if a woman is known to mental health services and wants to give birth, things like she has a 32-week meeting with multiple professionals, including a perinatal psychiatrist. You might be referred to perinatal psychiatry for sort of appointments throughout the pregnancy to discuss medication and stuff like that. So ideally, preconception, all of this, the best case scenario is to do it before the mum is pregnant, the woman is pregnant. But often, that happens without sort of it being planned. But ideally preconception, but it can be done during pregnancy. It's just obviously not as ideal because risk. I guess important thing to point out is this: unless any of us becomes a perinatal psychiatrist, we're not going to be doing this. No worries, Lizzie.
Right, cheers, Ahmed.
No worries, guys.
Oski. Yeah.
What's that? Oh.
A question. What about the PPH Oski? Yeah, you would. Yeah, absolutely do Dr. A to E and then do some of the specific. So do Dr. E, then start the specific medication, and then be like, if none of these are suitable, then I would discuss with Obs and Gynae and get them into theatre for further intervention.
You would start, as Anish said. Can you hear me? So yes, you can.
Yeah.
You would. The drugs that I listed come into the circulation part because it obviously have circulatory collapse. So you go through the A as the airway compromise, hopefully not. B, and then when you get to C, you'd be like, okay, this is when I want to start my medication and do this, blah, 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 and give fluids and all that kind of thing. And make sure you call for help first, because that is the most important thing, because you should not take on postpartum hemorrhage alone.
Yeah, definitely do that.
Yeah. So you would basically go through and then do the specific stuff. But do Dr. ABCD, and then when you get to circulation, you would start doing the specific stuff. Does that make sense?
Is there anything you can give IM, Jess, during PPH?
I can't actually remember. Yeah, I think there. You give the first thing IM.
Is that
I can't remember.
Okay.
I think you can give it IM, but I think they want to. I think preferably you'd give it IV because it acts faster.
Yeah. No. Yeah, I'm just trying to think of. Yeah. Oh, the carboprost is like the only thing you can.
Oh
really
yeah, that was
provide.
IAM.
Yeah.
But yeah. So you can't, but you don't give that before the syntocinon. So yeah, no.
No.
I was just thinking, is there anything you can give earlier than C? But no, there isn't. There really isn't.
But yeah, in your C, you would still put like bilateral cannulas in, give fluids in one, like get the nurse to take obs, all that kind of thing, and then you would go in with the, okay, now I want to start this and start my like uterine massage and that kind of thing.
Yeah. I also, like, if you can, like, you want to get like, is orange is the biggest cannula, right?
I thought it was grey.
No, gray's second biggest.
Oh, Jesus.
You want to get the biggest freaking cannula you can for a PPH. Like, I think, yeah. So I think it's orange is like the biggest. If you can, try and get an orange in, because this is like honestly the scariest thing I've ever seen in my life. Oh, I should stop the recording.